Right, I'll hand it over to Bharath.
Thank you, Lekansh. So these slides can be reproduced as a whole with acknowledgement to Anseco. So I'll start with a brief outline. I will cover some historical aspects, some nosological status, the conceptualization and controversies regarding this topic, some etiological models, the way people use to assess the various forms of addictions, and some treatment aspects. So unlike my predecessors who started historical sense from the Rigveda, I will have very brief 25 years to cover. The internet became commercially available only in the last 25 years. Early 1990s was when internet became available to everyone. And one estimate from the International Telecommunication Union based in Switzerland says that there are about 3.2 billion people, that is about half the population, that are using internet by the end of 2015. And of which are about 2 millions coming from the developing countries. And in the developed world, there are 82% people who use internet at home, and there are 35% of people using internet at home in the developing world. So somewhere 4 or 5 years after the internet became available, and probably a year or two after DSM-4 was introduced, a New York psychiatrist, Dr. Ivan Goldberg, he devised a list of symptoms. Basically, he modified from pathological gambling, and he named it internet addiction disorder and put it online. He also created online internet addiction support group, and basically he did it as a joke, and he did not mean it in a true sense. But over time, he realized there are a lot of people logging into these support groups and would tell their current situation and how they have become addicted to internet. And so from then on, there are a lot of research coming in this area. So this slide will show you some from the number of publications that are done each year in this internet addiction starting from 1996. You can see there is an exponential increase, but still the number of journals which come out is about 100 to 200 at the max, which is very, very less compared to any other topic of research in the current. So internet addiction research is quite still in its infancy. So ICD-10 came in 1992, which was too early for it to think about internet addiction. DSM-4 came in 1994. DSM-5, which came in 2013, does not recognize internet addiction as a separate disorder. However, internet gaming disorder was included in appendix for disorders for future consideration and study. ICD level, which might come in 2017, is also expected to follow similar trend. Is that it will not recognize internet addiction as a separate disorder, which was published by Grant and the working group on obsessive compulsive disorder on the ICD level. So what's in the name? So as I said, people call it internet addiction disorder, saying that this is the behavioral form of addiction. So there are also other group of people who model on pathological gambling, who say this is not addiction, this is pathological gambling kind of an issue, hence pathological internet use. There are other group of individuals who believe it is a impulsive compulsive spectrum of issue, and hence they would like to use compulsive internet use. And the other group would use it, call it compensatory internet use, wherein people compensate underlying anxiety, as we saw in a previous case. There are another set of people who say there is some problem, we don't know what is the problem, let us call it problematic internet use. So what are the different areas where people supposedly get addicted? So as we were discussing earlier, cyber gaming is a major form of online addiction, so to say. The massively multiplayer online games, most of which will be covered in the next didactic by Dr. Arun in the next session on Tuesday. Just to reiterate, the massively multiplayer online games include 4 major varieties: the role-playing games, the first-person shooter games, the real-time strategy games, and the turn-based strategy games. So these are the 4 main subgroups among the cyber online gaming. So there are other cyber sexual, wherein main theme of the internet use is for viewing pornography, is the other subtype of individuals who use internet in this proportions. And the other would be cyber-relational, that is using online for social networking and other purposes. So the other subtypes are minor. The information overload is just going through a huge volume of information available on the Google. Cyber gaming is something which is similar to pathological cyber gambling is similar to pathological gambling. In fact, it is used as a specifier in DSM-5. Cyberchondria would be something very similar to hypochondriasis. There is cyberbullying. I'll just try to cover some of them in the next coming slides. So, cybersexual is basically internet sex addiction. Typically involves viewing, downloading, trading online pornography, engaging in adult fantasy role-playing rooms. Cyber relationship would be online friendship or affairs that replace real-life situation, and an important and exclusive mechanism to relieve the underlying stress or loneliness or depression. This is not an exclusive phenomena where people with on social networking site also involved in gaming and cyber sex and so on and so forth. So it's not an exclusive. So this says that cyberchondria, cyberbullying, cyber suicide, and cyber sex are the new psychopathologies for the 21st century. Basically, it is the same underlying illness which is manifested in a different form. For example, there is health anxiety. There is excessive repeated online search for health-related information, which increases health anxiety even more. So there is a bidirectional relationship, and this is what is cyberchondria. Cyber bullying is another form wherein there is person does not use a physical strength to overcome the victim, whereas his proficiency in the technological would be he would use that in the digital media to bully a victim. So there are so on and so forth, so many ways to look at what people do on internet. So is there a consensus on the prevalence? No. There are studies from Italy which say that prevalence could be as low as 0.8% to 13% in South Korea and 26% in Hong Kong and about 38% in China. So there is a huge variation among the prevalence that is quoted across studies. So the major problem would be there is no consensus on what internet addiction is. For different people, it is different thing, and diagnostic criteria or measurement scales are different. And some studies use the same scale, but they use a different cutoff to say what is internet addiction. Most of them have convenient online sampling, which has a lot of bias, as we can understand. Most of them are self-report surveys rather than clinical internet. And there's going to be a huge socio-cultural influence. For example, in the Asian studies, which quote a very high amount of internet use and proportion of addiction, we can see South Korea. For example, South Korea is considered the most wired nation among the entire globe. They have they are still the number one in the internet speed, and probably they have a very high broadband internet going to almost 90% of the houses, and at a very cheap rates, and starting at a very early time in the when it was available. So probably is it a socio-cultural phenomena which explains this disproportionate prevalence among some Asian countries. So coming to Indian scenario, there are some studies which say the prevalence is ranging from 0.3 from Madhya Pradesh, which examined some students, and to 0.7 in Mumbai, and one of the ICMR study, which is not yet published, coming from Bangalore, says that somewhere it ranges from 3.5 to 5% in the social networking. This is not just restricting to the students, but across a wide age group of population, starting from 15 years to 65 years. So this probably gives a broader sense of prevalence in India. And also they find that there are strong positive correlation between internet addiction scores and scores on depression, anxiety, and stress. So is there a consensus on the diagnosis, on the definition? No. Some people like to akin internet addiction to phenomenon which is time consuming, uncontrollable, distressing, which is very similar to definition of an impulsive compulsive phenomena. And some would like to use a duration criteria, saying that use of internet for more than 6 hours a day for 3 consecutive months is addiction. Whereas some would link it up more with other forms of addictions like loss of control, excessive use to the point where the person experiences problematic outcomes that negatively affect lives, This is what people would like to. So basically, there are 5 schools of thoughts. There is a group which believe excessive internet use is addictive disorder. There are other groups which believe it is a impulsive compulsive spectrum disorder, wherein person uses to overcome uh, various others underlying disorders. And there are other groups which believe it is merely a reshaping of already established diagnosis like social anxiety, like depression, like OCD, which take a new phenomenological form in the form of internet is just a medium to express the underlying psychopathology. The other would be to view them all in a continuum approach, whereas it can be seen ranging from impulsive to compulsive to addictive phenomena. Is it that it is a continuous process, and an individual can and at any given point across the continuum. And there is another important group which believes it is not a disorder at all, and it is rather a socio-cultural phenomenon, and it should not be medicalized at all. So fine. Coming to 1996 was when reports of internet addiction started coming. So this was Kimberly Young in the first report of internet use, psychology of computer use, addictive use of internet, a case that breaks the stereotype. This was published in 1996. So here she describes a non-technologically oriented 43-year-old homemaker who was content with home life, no prior addiction and psychiatric history. Within 3 months of discovering chat rooms, that was the time wherein various chat rooms like Yahoo and Google Chat was much more used than the Facebook and other networking sites. She started spending nearly 60 hours per week online. She reported feeling excited in front of computer, depressed, anxious, and irritable when she would log off. And within 1 year of purchasing her home computer in 95, she was ignoring household chores, had quit social activities she used to enjoy previously, had become estranged from her 2 teenage daughters and her husband of 17 years. So she described these are various different phenomena of tolerance, mood modification, withdrawal, and salience, which was happening in this case. So a lot of behavioral addiction research comes from Griffith's model of addiction components, wherein he describes there are 6 major components of addiction: salience, use of internet to modify one's mood; tolerance, withdrawal, conflict, and relapse. Based on this, there are many other models where the Young's model of internet addiction was published in '98, and 2010 Tao et al. From China published another set of criteria for diagnosing internet. Basically, the all of this can be grouped into the same 6 subheadings. I'm not going to go into each of these details in the slide. Whereas you have to understand that the same components of salience, negative mood management, tolerance, and withdrawal, and conflict or external conflict consequences, and relapse and control have been the major themes of to diagnose internet addiction in the. So there is another set of group of people who believe it is an impulsive compulsive spectrum disorder, wherein there is maladaptive preoccupation with internet use, experienced as an irresistible urge to use, and for periods of time longer than intended. So there is a very much similar to impulsive and compulsive phenomena. There is an irresistible urge which is very distressing, and person uses even though it is distressing for a prolonged period of time, and hence they say it is very similar to impulsive compulsive spectrum disorder. So this was a study recently published in Psychopathology, which has done a review of almost all the 20 articles which reported of comorbidities of internet use with the other psychopathologies. So majority of these studies were coming from Asia. Most of them were cross-sectional designs, and they say that ADHD was seen in almost 100% of the articles. That ADHD was reported as a comorbidity in almost all the articles. Depression was there in 75, hostility, aggression was reported in 66, OCD was there in 60% of the article, and anxiety was reported in 57% of the articles. And they also said that there was strongest correlation among depression and the internet use, and the weakest was among the hostility and aggression groups. So probably what it implies is that comorbidity implies a common vulnerability to different phenomena of the expression of the disorder. So probably some underlying impulsivity and cognitive factors could be similar to this shared vulnerability. So coming to some of the etiological models. So I will briefly go through various learning, cognitive, social skills, reward deficiency, and some neurological perspectives. Uh, the learning theory basically says that in use of internet works in the operant conditioning format, and internet use induces feeling of well-being and euphoria, and hence it works as a positive reinforcement. Whereas negative reinforcement is that person, as we saw in our case in the previous this one, is that the shy and anxious individual would avoid anxiety-provoking situations such as face-to-face interaction and use the medium to overcome the social anxiety. And hence there would be avoidance conditioning and increase of the behavior. So Davis in 2001 said he conceptualized use in the cognitive behavioral perspective. There are unique internet-related cognitions and behavior, majorly revolving around self-doubt, self-focused rumination, low self-efficacy, negative self-appraisal. Whereas all this could be understood by underlying psychopathology of depression, social anxiety, and substance other substance. Social skills theory is from Kaplan in 2010. He says there are deficits in social skills. A person either lonely, as in social anxiety, or depressed in depressive disorder, would have a low self-competence, would prefer computer-mediated interactions, which because they offer greater flexibility in self-presentation. They can easily omit or edit information regarding the self, which are perceived as negative or harmful for others. So hence, he said deficient social skills was the major theory. And there are reward deficiency theory, which suggests that there are individuals who achieve less satisfaction from natural rewards like food, water, and sex. They turn to substance to seek enhanced stimulation from reward pathways. And internet use provides an immediate reward with a minimal delay, much similar to the stimulation provided by alcohol and drugs. And hence, these are individuals who are deficient in rewards, and hence they become, they start using internet excessively. So some neuroscientific approaches would be to understand the reward and executive models, brain functioning models. I have briefly covered some of the studies. I will not present a comprehensive view, but some major highlights. So before that, what the usual research say that there are substance use which causes neuroadaptation, changes in brain structure and function, and hence these are the reasons for the problems of addiction. And behavioral addiction researchers also report that there are excessive online behaviors which causes neuroadaptation and hence problems of addiction. Whereas this may not be entirely true. The excessive online behaviors could be just evidence of learning. So we should probably focus more on the underlying diathesis or underlying, which could be similar to substance use or it could be entirely different from substance use. Whereas we should probably understand more about the underlying processes which happen. So this is one of the studies which used dopamine transporter specs involving study, which very minimal small sample size. What it shows, the top row is the internet addicted individuals and the bottom row is the control. As you can see, the orange and the red and the yellow color looking the center of the brain would be the striatum and the expression of the dopamine transporter levels. And they reported that dopamine transporter levels were less in the internet addicted individuals and more in the compared to the controls. So what? But even though this would be meaningful, they argued that these findings suggest that internet addiction induces dysfunction in dopamine brain dysfunction. They do not view it as a vulnerability, but whereas they view it as a function of internet use, and hence the internet use causes certain brain changes, and hence it should be considered as a separate diagnosis. So this is another study which looked at MRI brain structure and brain structure mainly. They say that the white matter in certain key prefrontal regions like dorsolateral prefrontal cortex, in the anterior cingulate, the orbitofrontal cortex, and the supplementary motor areas were less in the internet addicted individuals, and compared to the normal controls, they were also able to correlate that with the amount of internet use. The more the internet use, the lesser the volume of the gray matter that was reported in these individuals. DTI also reported some interesting findings. They said that fractional anisotropy, which is basically a measure of the integrity of the white matter tract, they said that the fractional anisotropy reduced in the parahippocampal gyrus, which means there is a white matter integrity, which is lost in the parahippocampal white matter, whereas it increased in the posterior limb of the internal capsule. So, which is the fractional anisotropy increasing means there is a better conductance of white matter tract. So, they found increased fractional anisotropy in the posterior limb of the internal capsule. And they also said that with the duration of internet use, increasing duration of internet use, the fractional anisotropy measures improve. They were not able to come to a understanding what is this finding, whereas they reported just saying that probably increased use the posterior limb of the internal capsule, which is mainly corticospinal tract, there is increased efficiency of transmission, and hence the motor component of the gaming or the internet use, there is increased fractional anisotropy. This another interesting study looked at the corpus callosum. This is basically a whole brain tract-based spatial statistics study, which looked at white matter tracts all over the brain, and they found differences only in the corpus callosum, the genu part of the corpus callosum, and also in the external capsule. They were able to correlate the white matter. They found there is fractional anisotropy reduced in these two areas, in the corpus callosum and in the external capsule. And the reduced fractional anisotropy, which means the white matter integrity which was reduced, correlated well with the anxiety scores in the genu part of the corpus callosum, which would make sense because the rostral anterior cingulate and most of the subgenual anterior cingulate is believed to be involved in depression and other anxiety disorders. They also found the external capsule also had reduced fractional anisotropy, and that correlated with the severity of Young's addiction scores. So this was one study. Before I go into this study, let me just go to the next slide. So I think you would have come across this slide, wherein there is the ventral to dorsal shift of the circuits in the striatum. So on the left hand side would be the nucleus accumbens, which is the ventral striatum, and on the right hand side is the putamen, which is the dorsal striatum. Uh, uh, from adaptive behaviors to addictive behaviors, there is a gradual shift of the functional circuits, whereas it becomes more of a compulsive phenomenon towards the right end of this spectrum. To the left end of the spectrum, it is more of an impulsive or a reward dependent phenomenon. So going back to the previous study, this is basically a resting state functional connectivity study, which looked at which made 5 seeds in the ventral striatum. They made seeds in the ventral striatum, caudate, and also in the putamen. In the entire basal ganglia, they made 6 different seeds, and they looked at how is the connectivity of these seeds to other regions of brain in the resting state. And they found that there was reduced functional connectivity from the ventral striatum and also from the caudate seeds to the other regions of in the brain. Whereas in the putamen seeds, you can see in the right hand corner that there was increased connectivity, and they suggested that there is a ventral to dorsal shift that is happening. The internet addicted individuals had a reduced connectivity in the ventral striatum and the caudate seeds, whereas they had more connectivity in the putamen seed, which is more of a compulsive or a motor dependent circuit. So these are some conceptual issues I have with internet addiction research. Most of them arbitrarily categorize groups into based on some various scales into one internet addiction group and the control group. Whereas these, as I said, there is no consensus among the diagnosis itself. So the categorical groups becomes invalid. Differences in activity of the brain areas are not enough to attribute a pathology which is attributable to the internet addiction, and hence we cannot justify at this level to say that internet addiction is a separate diagnosis. These differences could also be attributed to depression, anxiety, or intellectual quotient, which are not controlled for in many of these studies. And most of these studies are cross-sectional in nature, and we do not know what happens to the functioning over a period of time. So way ahead would be to use dimensional groups, model relationship between internet use and the brain function, and also to look at vulnerability and longitudinal study. So this is one study which looked at genetic polymorphism in the cloning just temperamental character. They found there are 2 different types of results. The internet gaming groups they were higher on reward dependent scores, and they also had higher prevalence of DRD, TAC1 A1 polymorphism, and lower activity of COMT. Which DRD2 basically means that there is lower amount of dopamine available in the lower amount of dopamine receptors available in the striatum. So they would use internet to get more amount of dopamine. And lower activity of COMT also would mean that these individuals have a lower enzyme which degrades the dopamine at the synapses. So this was one interesting finding. And the other group do not have gaming but other forms of internet. They found higher harm avoidance, and they also find higher prevalence of serotonin transporter gene of the short allele. Short allele basically leads to reduced expression of the serotonin transporter, and they also correlated that with the depression score. So because of short of time, I will run through following slides. Gold standard at this point of time is only clinical interview, because this is a spectrum of issues which cannot be understood by a single scale. Nonetheless, for research, people use Griffith's criteria or Kimberly-Young's criteria. There is one criteria coming from Taiwan and the other criteria from China. And for severity, people have used across many studies the Young's internet addiction test and the Chen's addiction scale. We will not go into the details of this. So coming to treatment, pharmacological interventions report started coming in 2004. This was a case report which used citalopram in 30 mg dose for 3 months, and they reported there was reduced time spent online, and there was also improvement in both. And in 2007, there was another case report with quetiapine and citalopram, and there was reduction in time spent. Another study in another case report from biological psychiatry was use of naltrexone 150 mg and sertraline 100 mg for a person who was having compulsive cybersexual behavior, and they reported that naltrexone alone would not have reduced the excessive use, but also naltrexone plus sertraline, they found there was sustained remission of the internet cybersexual behaviors over 3 years of time. So these are all reports coming from case report level of evidence. There was first study in 2008 which started as an open label phase study of 19 individuals, 10-week open label use of escitalopram for 20 mg, and they found that 65% of individuals reduced time spent on the internet. And they then next moved on to the randomized part of the study, and either these individuals either received internet, the escitalopram or the placebo, and they found there was not much difference between the group. There was equal efficacy among the these three group of studies comes from the same researcher from China. They have used methylphenidate in a dose ranging from 18 to 54 mg in 62 individuals who had internet addiction and also comorbid ADHD. These were drug-naive children. Their study lasted for 8 weeks, and they found considerable improvement in neuropsych functioning in the form of continuous performance test, and also reduced time spent on the internet. They also did a pilot study on bupropion. They used 11 internet addiction individuals and 8 healthy controls, and they used it as a measure to see if there is any change in brain activity. The initial there was reduced desire and time spent on the internet and on the games with bupropion. When you compare the brain activity, there was not much difference between the healthy control and the internet addiction groups. And they next went ahead with randomized control trial with 50 individuals for a 12-week period, 8-week treatment with followed by a 4-week follow-up period. During the 8 week of treatment, there was reduction in depression scores, and in the follow-up period, it was comparable. I mean, there was reduction in time spent on the internet. So let me move on to psychosocial interventions. In 2005 is when the literature on psychosocial intervention started getting published. Started with cognitive behavioral models, solution-focused brief therapy, and also with family therapy. So there are some evidence early in the time. And Young report, Kimberly Young's took a 3-step approach, modifying dysfunctional thoughts, learning new coping skills to prevent a relapse, and time management in 114 individuals, and found there is some improvement. Later in the she also published this in the Journal of Cognitive Psychotherapy. There are 3 steps. She modified her previous study and the initial starts with a behavioral modification and followed by cognitive restructuring and followed by harm reduction therapy. So the other forms of interventions would be time management skills, which was done in 56 individuals. There was improvement in time management skills in the people with internet addiction. There are combination of CBT with bupropion, and there is a combination of group therapy, individual therapy, social skills training, and in another group of study, which also reported some improvement in the. So to summarize, at least 3 major subtypes have been identified: cyber gaming, cybersexual, and cyber-relational. Comorbidity is the rule and must definitely be looked for in all cases. It is premature to recommend any evidence-based treatment, as you can see, there are only a slight few of studies which are published in internet addiction. Preliminary studies suggest there are treatment such as CBT and methylphenidate, bupropion, or SSRI seems promising. So I would like to finally leave you with an enigma wherein most of the diagnosis, validity of a psychiatric diagnosis should go through Robin-Guze criteria. So we are, for internet addiction, we are still in a very infancy stage. We are not yet finalized on the clinical description, let alone laboratory studies. Exclusion of other disorders is definitely not possible at this time. Follow-up and family studies are very far and few. Thank you.
Thank you, Bharath. That was indeed very informational and critical review of internet use disorder, pathological internet use, whatever. I would like to invite some quick questions. We still have around 10 to 15 minutes with us. I think one thing is, how many of you agree or disagree internet addiction is a disorder from the audience? And yes, why so, and no, why so? Okay, unmute and go ahead. So I think already a response came. Bijayawada, Dr. Ram from Bijayawada tell yes, he's an educational counselor and he feels that internet addiction is an issue, whatever name you want to give. Any thoughts from here? Let's ask here itself.
Some observations which I made over the presentation is that, when we see that in one of the comorbidity study, 100% of them had ADHD. And this is also the group which also seems to have a lot of social anxiety and such kind of spectrum of symptoms also, anxiety-related spectrum. So, which again proves to the point which we keep discussing again and again, that the internalizing and the externalizing do not probably occur as in, they coexist as a rule rather than an exception. And the other possibility is that the group is very heterogeneous which we are studying, and there may be, we may be able to tease out a few subgroups with specific comorbidities also when we do much more research in this. And the second comment is that we keep coming back to Robinson-Guze criteria when we want to diagnose a psychiatric illness. But maybe it's 45 years from then and we have not been able to have any psychiatric illness which will go by all the criteria of that. So probably we need a different benchmark now to benchmark rather than keeping it as the benchmark for diagnosis. Maybe it is the existential part of it that we should accept that Robinson-Guze number stands valid in diagnosis.
I wouldn't completely agree with it. I mean, we can lower down the benchmark if we are not performing. That's the easier way out. But say for disorders like schizophrenia, bipolar, I mean, there are arguments that there are no more twin discordant, there is no more a dictum that twins can't be discordant for these two disorders. But they are exceptions. Exceptions prove the rule, right? But it's not that we cannot satisfy those criteria for a lot of psychiatric disorders. I think Dr. Indumati, you have agreed that it's addiction. I think there is a split house here. Some people feel it's addiction, some people feel addiction. I mean, can you share your views? Yeah.
In Bangalore, I will say it is not a separate disorder. It is just another symptom because of the social and the technological advances which are going on of various other psychiatric disorders. One of the evidence is because it's a comorbidity is there very high, 100%, and also even the the genu of the corpus callosum and the other things also, mostly correlating to the anxiety or depression or any one of those, whatever we have already got it. It is just only a different symptom of our already existing disorders up to ICD-5, DSM-5. So still it has to be for a clinical consideration later on. Thank you.
Right. I think, yeah. Lekhans, any comments to Madam's questions?
Probably Bharath could.
Yeah, I think even we would share with your point of view. And this would be very premature to call it a separate disorder. But that doesn't mean that we should not further research into what is the phenomenology of this problem. As you rightly said, there is comorbidity is rather a rule rather than an exception. And yes, I think we will have to go ahead and I don't think ICD-11 will include internet addiction as a separate disorder. It is as we don't have a diagnosis for future consideration in ICD-11, we'll not even have a mention of internet-related disorders in ICD. Probably some of these phenomena, like for example, cyber-sexual disorder, would go into other forms of diagnosis. For example, ICD-11 is going to remove some of the diagnosis of over sexual drive, disorder of increased sexual drive, and put it into a compulsive sexual phenomena, compulsive sexual disorder, wherein this would fit into the other phenomena where there is more. And as I said, online gaming, online gambling, they would all fit somewhere, but would not get a separate diagnosis at this point.
Saurabh has a point. Long-term internet use, bar gaming, related brain changes, positive or degenerative, is used to consider. It's a view actually. We don't know where it lies. Is it a positive change or degenerative change? Right. Any other comments before we wrap up the session? From here, what do people think?
Somebody want to raise perspective? I think it's predominantly. I agree with what has been going around. I think looking at every phenomenon, we're just trying to tease out things on the surface. Right? I think there's something much more that is there, and keep looking further and further to actually find what it is that underlies various things. It's not only for behavioral addictions, the broad spectrum of addiction and addictive disorders themselves. And the classifications in that sense will keep on changing over a period of time. Does not mean that we should stop classifying. That is something that we should be careful of. Obviously, you need to look at what leads to things, but if you don't classify, you will not further research in it.
Yeah, it's a good point. I mean, classification at least sometimes it's like splitter versus split seeds. But when you look at the case that was presented first time, I mean, we know that there are a lot of issues, but because of internet or gaming was the issue, the family brought you to family get you to here. So often this might be a medium to get a seeking help, but then obviously a treatment perspective it goes beyond the part yeah.
I will also be a little more critical with this area of internet addiction per se. Like, there are people who had made their career out of this thing, and unfortunately, most of the researchers are junk researchers because they've all gone into some university. Will just check with people whether put Young's internet addiction scale as such, and make them to fill it up, and then they get some scores based on that. They say that this much prevalence is there. Most of this thing from India also there are many studies which has come up but these studies are not leading us anywhere. It can't be looked at in that way. As a clinician, sitting in this place, whatever cases we get in over here, we always see them with lot of other comorbid things. Let's say 100% comorbidity of ADHD. It may not be ADHD being the 100% comorbidity. There are other issues also are comorbid as well. So internet addiction is something which is very difficult to define per se, because again it is the same as food addiction, exercise addiction, and all those things which comes up. The newer fancy diagnoses which are coming up as such, like, because these are all something which is becoming more and more essential for livelihood as such. There are people who come with problem. We have to serve them. Like Lekhan had discussed on the day, like we can be critical of it, like, but there are people who come with this is a problem. When that comes in, we have to analyze it completely and we have to help them out as such. Like, I don't know how this research will go up without much of follow-up studies with like internet addiction disorder per se, and follow them up for years together and decide what's going to be the results and all those things. It's a long way to go. Like at least whatever research which has happened should not have led even in the appendix also the internet gaming disorder.
Okay, thanks, Arun. Vishal, would you like to unmute yourself and go ahead? A very important point to mention. Dr. Vishal, yeah, please go ahead.
Yeah, I was.
Yes, go ahead.
Hello.
Yes.
Yeah, sorry, my connection is really bad today, so I could not hear everything. But I think since we're looking at these compulsive behaviors in a way, I can say. So that's why I was thinking whether we can look at from the OCD spectrum issue also, because now recently we are also looking at addiction as a type of obsessions in a way. If you look at the circuits involved in the brain in prefrontal cortex, so that's why I was thinking from that angle loosely. So I just wanted to comment on that.
I think that's right, rightly so. I think probably past couple of slides, Bharath was speaking about more than obsession, impulsive disorder, compulsive impulsive spectrum disorder. So I think your point is absolutely right, and looking at neurobiological changes, at a certain point of time it become a obsessive behavior. I think you agree. And the first case which was also discussed today, case discussion, as that Arun was mentioning, the critical point was giving sertraline, where some of the things were broken, although the anxiety was symptom, but again, serotonin path, prefrontal orbital cortex is completely definitely involved, and I agree with complete point. Also, Anubhav's point is that ego dystonicity probably phenomenologically is a different thing. But again, you can ask a guy who is regular substance user why you drink, but there is no answer to that. It's just like ritualistic behavior goes on and goes on and goes on. So I think we agree with both the points that there is a spectrum of obsession.
Like Vishal had said, in like alcohol, cannabis, or opioid, all those things are there for some time, and people are seeing some problems with that, and there are social issues with that. Like, so we might be willing to agree that they are disorders, but when it comes to our internet, something which is new, no rules are there, no set things are there. So I think we are not willing to admit that as a problem per se. Like, but when we look at the comorbidity, I think there are a high degree of comorbidity even with substance use disorder also. So in that sense, I feel like everything is the same.
Obsessive compulsive spectrum.
No, I don't want to put it as obsessive compulsive spectrum because I don't want to fall into obsessive compulsive. But yes, these are all spectrum of behaviors.
Compulsive, impulsive. I think they recently are telling it's a compulsive, impulsive group of disorders. Correct.
Clarifications and suggestions. I think it's time we wind up today's session. Thanks to all of you for joining. I hope it was worthwhile. So we'll meet you again next Tuesday, same time, on your screen.
Yeah. Thanks to all of you for your time and coming to the forum in spite of busy schedule. We have just one announcement. The next module, next session in August, we are going to do an adolescent, most on preventive adolescent. So we requested one of the faculty to take something on life skills training. We thought it will help a lot of us who are of an adolescent field. I will announce you in due course and you'll get the things. Thanks to all of you. We'll see you next time.